going. First, I want to say thanks to Dan Golden and everyone else that's part of the team for welcoming me here today, and all of you for listening. I'm going to insert a little bit of a personal background just to explain why this became of interest to me when I first started out as a PGY2 resident. So when I was a medical student, I was at University of Washington, and I had arrived there excited to be a learner, learning how to become a good doctor, and found myself the first year and the second year sitting through hours upon hours of didactic lectures. And it sounds like it might have been similar to what Dr. Ingledew had referenced when, it was prior to any sort of curriculum overhaul, and it was extremely bland. I think probably during one of my second year lectures, I was wandering the internet and found this New York Times article about how PowerPoint is the death of us. This actually had this image had sort of ricocheted around the internet in 2010. It had to do with military strategy in Afghanistan, and General McChrystal had said, he was one of the leaders of their forces there, had said, once we understand this PowerPoint, we will have won the war. And later on, James Mattis said, PowerPoint just makes us stupid. So this kind of experience I had as a first year and second year medical student was very much in stark contrast to my time when I was a teacher, actually a middle school teacher in South Texas. I lived in the Rio Grande Valley there, and I taught in a little town called Donna. But anyway, prior to working there, as 2 years teaching middle school science, I had to undergo a 6-week boot camp of how to actually teach. And because most of us that go into this program do not have education majors and have really no background and just a passion for teaching and being a part of kind of this movement. So there's this, as you can see the top left, is a 200-page kind of book that we had to read and engage in various seminars. There are a number of these during that course, that 6-week boot camp period of time. But a couple things that I kind of took from this this piece of my earlier training, pre-medical school training, was when you create an instructional plan, it's critical to carefully consider what your students are doing during each step as they go through their learning process. And that a teacher must ask themselves at every point of that curriculum design, what are my students doing? And you have to be aware that children and adults and all humans learn as not as passive agents. So you have to build activities in that will allow students to take in the information. So again, this is basic pedagogical theory that was taught to me to teach elementary school kids and middle school kids, and it's very true for all of us. So this is what my classroom looked like at the University of Washington. Again, I'm very grateful for my education there, but it was a little dated. And it definitely ignored some of the fundamentals of this kind of pedagogical strategy. Bloom's taxonomy is something that people will talk about in basic educational classes. There's a medical version of it, and it's been published and talked about. And I felt that as a first and second year medical student, we were stuck down here at the remembering piece, and that was about it. Someone had mentioned earlier some commentary about the flipped classroom in medical education, and I'm sure this is not a surprise to many of you who are interested in these types of topics. But this is a review article supporting this as a kind of an approach to medical learning, and basically had highlighted a lot of different studies that had done their own analysis on this approach, and basically found that lifelong self-directed learning skills are perceived by medical students to be enhanced by the flipped classroom model, where instead of someone like me is standing in front of all of you just talking at you, people are actually sitting and discussing and debating and teaching one another, and you have an expert facilitator there. And again, I think like you had said from University of Alabama that there are medical schools that have this in place, but mine certainly didn't when I was there. So this is just looking at the review article and all the different studies that they reported on, stating that this is a good approach to use. I won't belabor those points, but it led me to wonder when I became a PGY2, how are most radiation oncology programs training the residents? Because I chose a program where a very sort of interactive teaching model is used, but I know from my interview experiences and just talking to friends that not every program has that type of system. So we sought to understand sort of the differences in program directors and chief resident perspectives on the educational environment of our radiation oncology programs around the country. And what we had done was we distributed an anonymous short survey. The survey assessed 3 different domains. I'll really just highlight one of them, which is that bolded one there, looking at the conference structure used during the dedicated educational time. And we did not only want to get a general sense of how people felt about the approaches used, but also wanted to do a little bit of a comparison between program director and chief resident perspectives. So one of the first questions of the survey was, what is the frequency of Socratic versus didactic conferences at your program? And I kind of had explained in the survey what that would mean. I think all of you probably understand what that is, but basically sort of that question and answer versus lecture-based approaches. As you can see here, the majority of programs, somewhere between, around 50%, are using a lecture-based approach, and very few are predominantly using Socratic. So on the far right, you see that it's about 20%. There's pretty good agreement between program directors and chief residents that Socratic approaches are relatively rare. So a subsequent question was, which approach do you believe is more effective? And what you can see here is that along the far right, the majority agree that Socratic-based methods are more effective. So it's somewhere between 50 and 60%, with 20% or less on the far left believing that lecture-based is more effective. So again, this is in stark contrast to the previous finding, just repeating that graph on the left, that there's a discrepancy where the majority of programs are using lecture-based approaches, and yet most people believe that Socratic approaches are more effective. So the next question was, and I'll get into this a little bit more why I think this is an important question, but which type of moderator do you believe is more effective as a facilitator or a teacher? And this is in part due to the understanding that a Socratic approach is going to require a little bit more investment, likely on the part of the staff physicians that are on your team. So there's some differences here. As you can see, the bar graphs look quite a bit different. If you look at the far left, over 60% of chief residents felt that faculty-led moderators would be more effective, whereas that number was much lower for our program director cohort. And if you look on the far right, that difference is there too. If you look in the middle, over 50% of faculty are saying it's fine for residents basically to teach their fellow residents, and many fewer residents actually believing that that's as effective of an approach. And I think, just as a side note, I think resident-on-resident teaching can be very good, and it's good to learn those skills of how to teach one another effectively. Sometimes those skills aren't actually developed though, and so people just propagate poor teaching methods or kind of uninteresting teaching methods. So it works for some programs, but I think partly too that there's an element of people's beliefs sometimes come from areas of convenience. And so I think it's good for us to understand where there's these discrepancies and be honest with ourselves about how we should improve our kind of programmatic structures. So I was actually preparing a portion of this talk for sort of my senior year, I'm a PGY 5 years, so I'm heading out soon, but and I had found that Emma Holliday, who I'm sure you know well, and a few others know well, had published on sort of how they evolved their classroom experience at MD Anderson. So until sort of recent years, what I understood from reading the article is that they had had very good protection of their time for learning, but had not used a Socratic approach. So they had, in 2015, a committee was appointed to kind of create a curriculum that could be utilized, and then it was deployed. This is 9 minutes.
You have a minute.
You have 1 minute. So it was subdivided into 1-week blocks, and then a follow-up survey was deployed to assess the efficacy. This is, I won't go into the detail about this, but this is just showing you kind of the basics of what they wanted to get across during that period of time. These are the 1-week blocks that they delineated, and again, this is all visible in their paper. But what you can see is in the left column, there's basically on a Tuesday discussions of seminal cases and some seminal papers. The middle column is on Wednesdays are going to have a Socratic component that they're always going to routinely use, and then on Thursdays there might be more cases, more papers, or some radiology discussion. In a follow-up survey, they had a number of residents and faculty respond. They all felt that the curriculum was an improvement. They were more likely to attend the sessions. They both agreed this intervention translated into improved clinical performance. So in conclusion, what I wanted to kind of get across today is that Socratic teaching in radiation oncology residency is highly valued yet uncommonly practiced. I think this teaching does require investment in it, sort of a change of culture and a change of an approach on the part of attendings and residents alike. And I think that that MD Anderson-based paper provides a great sort of blueprint for change, and with their post-session follow-up shows that most of the participants were very happy with those changes. So I want to say thank you to all of you for listening, and I'll take any questions.